Okay, just another moment to allow a couple of people to join, and I know I'm getting some questions in the chat as well as some permissions to record. So we will process those and then begin shortly, if that's okay. Director McLeod and Dr. Vanderhoff with you.
Yeah, that's fine with me, but Bosco's not allowed to ask a question. Take him out of the loop. Tom and I graduated together from OU in broadcast journalism.
Dude, I'm standing out here in the cold, shooting in the back out of the back of my car. I'm shooting.
Oh my!
I know. Not like we were told it was going to be, right, buddy?
Not at all.
Can you provide everybody with permission to record?
I am going through individually. Is there a mass way to do that? I apologize if that's a rookie question here.
That's a good question. I don't know.
I have no idea.
If you do have a request to record, please put it in the chat and I will continue to do those individually. It'll just take another minute. Okay, I have processed most of the requests to record. Thank you for putting, if you have your questions, in the chat. And I am recording this locally, and so anyone who wants that after can also request that file if we didn't get to you. Director McLeod, if you'd like, we could go ahead and dive right in.
Great. Thank you, everyone, for joining us this afternoon. It was my understanding that our media team, as well as some of us individually, have been receiving a lot of questions about the governor's announcement yesterday. It's a lot of announcements in 24 hours. It's an exciting time. We will try to be quick. I know you all have deadlines and you're moving very fast with all the information that's being processed today and yesterday. So we'll move very quickly through that. Just a quick update. Primarily, Dr. Vanderhoff is going to be the expert to answer your questions, but I will also be available. I may be muted. There's construction going on in my building, which is very loud and from time to time. So I'll do the best I can. Thank you, Dr. Vanderhoff. Oh, and by the way, today's his birthday. He made a rookie mistake of trying to take the day off. So Dr. Vanderhoff.
Thank you very much. Appreciate it, Director. Well, you know, I thought what I would do is begin. Alicia, do you have that slide that you could share that shows the calculation? Very good. Let me see if I can fix this so that I can actually see what we're looking at here. So I want to begin with this, and then I'll move into some quick comments. This slide illustrates exactly how the measure that the governor referenced yesterday is calculated. So we have an example up there of the current number that the state's reporting out of 179.6 cases per 100,000 residents. That's for the 2-week period from February 17th to March 2nd. All of that data is pulled from our Ohio Disease Reporting System. You've heard a lot about ODRS in the recent weeks as we've talked about the death reporting system, but much more of what ODRS is about is collecting a vast array of other important information about a variety of infectious diseases. Of course, one of those is COVID. We then use that to calculate the total cases. Now, this is confirmed and probable, and I'll explain that. That is just those terms actually just really refer to PCR and antigen tests, PCR being the confirmed and antigen test being the probable. As we now know, when we're talking about positive cases, which is what we're talking about here, both of those methods of testing are very, very accurate in terms of their true positives. So it is a good way of capturing, especially in a state which, like ours now, is doing large numbers of antigen tests. It's a good way to capture the actual positive tests across the state. But importantly, we look at the date of onset, not the date that is reported. So as those are submitted, they're submitted with an indication of the date that the patient's symptoms began. And we use that as the relevant date. And for this calculation, we looked at the time, the 2-week time period from February 17th to March 2nd. We then consider the total population of Ohio and then multiply by 100,000. So that's how we arrive pretty simply at the calculation of cases per 100,000 over a 2-week interval. And I'll stop there. I have some additional sort of background or comments I can make, but I'll pause there and just see if we have any immediate questions. Okay. Let me go on and just share a few other thoughts and a little bit of background regarding this. Ohioans have been telling us, and I think this is very understandable, particularly in the context of much of what is going on around the country, that they want to get their lives back to normal, but they're Ohioans, and so they want to do it responsibly. They have wanted a mile marker, something that could be a reasonable signal to them that our vaccinations are having enough of an impact that mandatory restrictions are no longer necessary. Now, as we considered that question, we did it in consultation with health leaders across the entire state. And as we were thinking about that, it became increasingly clear that this measure I just reviewed with you, the cases per 100,000 averaged over 2 weeks, by the way, a measure that we in the CDC, the cases per 100,000, that's a measure that we in the CDC have been tracking from nearly the start of the pandemic, that was the right measure. Now in Ohio, we have measured this as a 2-week average because of our focus on wanting to understand sustained trends. We really do not want the noise that comes from random daily variations to confuse the picture. And as we look at that measure, we're confident that if we drop below 50 cases per 100,000 and do that over a 2-week window, we will have dropped for a meaningful period of time from where we've been, a rate that the CDC has considered not just high, but very high transmission, all the way down to much more moderate levels of transmission that frankly we haven't seen since way back in early June. So dropping below this marker should be a good indication that there's enough immunity in Ohio that the virus, even in the face of infectious variants, is less of a threat. But I also want to be clear that while we set this milepost, we did it in the context of multiple other measures, which we've been sharing with you, that are pointing in the right direction. But we also did it in the context of understanding that people really want a straightforward measure that they can follow. And this is what we believe it to be. So I'll stop there and see if there's anything else that the director or I can address.
Thank you, Dr. Vanderhoff. One other comment I wanted to make is that we have always kind of had this average made available on Thursdays. We will continue to do that. Again, that helps avoid the fluctuation. So those numbers will continue to be available every Thursday weekly. One other kind of off topic, but some of you may have questions, so I just wanted to let you know in advance. The death numbers, as we've talked about, we moved to an EDRS system, and it's reporting out twice a week, Tuesday and Friday. Today's death numbers look a bit higher. They're going to report 752 deaths. And I just wanted to make sure you understood the kind of the impetus behind that comes primarily from, we have 428 of those are out of state. They are Ohioans who have listed their primary residence as Ohio, but they've gone somewhere. We don't know if it was short-term, long-term, could be snowbirds that have gone to Florida. We don't know where they contracted the virus, but they passed in another state. We have a cooperative agreement with most states where we provide this information back and forth. And as you might imagine, some states get further behind than others. As we were making that move to the EDR system, I specifically asked our team at Vital Statistics to reach out to those states that we maybe hadn't heard from recently to make sure that our information is up to date. And I think that increase in the number of out-of-state death certificates we received is in fact kind of the outcome of those efforts. I just wanted you to be clear. You'll see 752 on the deaths. We'll put a disclaimer up there, but 428 of those are out-of-state death certificates, but the person has still listed Ohio as their primary residence. It's possible that they have moved to another state, but had not changed their primary residence because it was recent enough, they just hadn't done that yet. It's possible they were snowbirding, any number of things, but I wanted to explain that. It raised questions for me. I assumed it would raise questions for you. So with that, we'll open it up to questions. Alicia, who's first?
Our first question is from Kevin Landers. Kevin?
Great.
Hello, happy birthday, doctor.
Thank you.
So I'm trying to understand the 50 cases per 100,000 number. What's magical about 50? And with testing going down, it could make it appear that we're not testing enough people, therefore the cases are going down when perhaps they may not. But can you explain what is magical about the 50 number? Why 50 cases per 100,000?
Very, very good question. And I'll start with that one, and then I'll comment on the testing numbers as the second question you asked. So it's important anytime you're going to set a benchmark to have some target. And as we were looking at this metric, the cases per 100,000 averaged over 2 weeks, we were able to look both at some of the markers that the CDC has set, as well as the history in Ohio. And again, remember, we're thinking about what's an indication to us that the amount of infection, the number of cases in our state has reached a low enough level that we can have a higher degree of confidence in lifting some of the mandatory requirements. And that's important. We will continue, I'm sure, to offer guidance and recommendations regarding safety measures that people should undertake. But this is a question of lifting mandatory requirements. And as we looked at that, two things became clear about 50. First of all, that is the threshold that the CDC uses for saying that you have dropped into a moderate level of disease transmission. The second is when we look back over our history, that's where we were below 50 during a 2-week interval in June, which was really our lull after we came out of our spring experience, our first wave, and we were actually, as a state, substantially shut down. And before we moved into our summer wave that came in July. So we have both good historic reasons to believe that, hey, when we're there, things are pretty quiet, and reasons based on the CDC's benchmarks for saying when we're there, things are quieting down. Remember, we've been in ranges that the CDC has classified as very high. So not just high, but very high. And we're talking about watching to see that we have regressed to a level of transmission that falls into the moderate and approaching very low transmission levels. Secondly, in terms of overall testing, look, no measure that we could pick would be perfect, but we have a lot of confidence in our testing program here in Ohio. And even as you look now, we're seeing very, very low rates of positivity, and yet still substantial numbers of tests being run. When I looked yesterday, and again, I didn't look today because it's my birthday, but when I looked yesterday, we were right around 50,000 tests. At our peak, we were doing between 60 and 65,000 tests. So we're still doing very large numbers of tests. And we have so many testing programs in place that I don't think there's a high likelihood that reductions in testing will signal a lack of appropriate testing. I think reductions in testing right now are really reflecting fewer people presenting with symptoms.
Thank you, Dr. Vanderhoff. Our next question is from Joe Ingles with Ohio Public Radio and Television.
Happy birthday, Dr. Vanderhoff.
Thank you very much.
My question is, we're still hearing from people who are not very computer literate, maybe don't even own a computer. They can't get through on the phone to some of these sites to get a vaccination. And they're saying, why don't we just have some DriveUp sites? Why don't we just have sites where we don't have to make, it's first come, first serve? Is the state looking at any of those kind of sites right now?
Well, I'll begin and then I'll turn it actually to the director because I think that she has even more direct information on this. But we are looking at all kinds of channels and opportunities for delivering vaccine to people in the state of Ohio. Much of the challenge we've had heretofore has been a supply issue. When you have very, very limited supply, it's very, very important that you are not putting people in a position of showing up and having nothing to provide them. So having a scheduled approach has really been the most customer-friendly approach that we could apply up to the present time. We're approaching a period where we're really increasingly optimistic about substantial increases in vaccine availability and looking at other ways that we can deliver vaccine that are more along the lines that you're describing. And Director, would you have more insight to share on that?
Thank you, Dr. Vanderhoff. Thank you for the question, Joe. We are looking at all options. Again, as Dr. Vanderhoff described, some of this will be based on vaccine availability, but having more mass vaccination clinics, large vaccination clinics, as well as drive-throughs is definitely something we are looking toward. One of the places I would love to have drive-through would be our local firehouses, as some of them apply to be providers when we're able to get enough vaccine to do that. That would be great. They can open the bay doors on each end, move one of the engines out, and just have the cars come through undercover in case it's raining, what have you. And they've got that team there in place. So we are looking at all forms of vaccination outlets, including drive-through.
And just as a follow-up, Jackie, I did see your related question flash up on the screen, and since it's related to the answer I just gave, and it's a good follow-up, I thought I'd just hit that one. Jackie asked about where on the CDC site one could see the cases per 100,000 over 2 weeks, 50, 100, et cetera. Actually, a couple of differences between the state and the CDC. We have always used 2 weeks. The CDC has primarily used a 1 week average number. Again, what I'm much more confident in a 2-week interval. And the folks here at the Ohio Department of Health, even before my arrival, were more confident in a 2-week interval. I think that is a more sensible approach when you're looking particularly at numbers at the level of a state's population. As you expand to the entire population of the United States, perhaps a week makes a little more sense, but we've always used 2 weeks as opposed to CDC using 1 week. That's just a difference in confidence intervals. And I feel much more confident in a 2-week average than 1 week. In terms of where they express those thresholds of 50 and below being moderate, then 50 to 100 high, and 100 and above very high, you can look at their travel advisory portion of their coronavirus website, and you'll find that there.
Thank you, Dr. Vanderhoff and Director. Our next question is Tom Bosco with ABC6. He's ready to go.
Hey, doctor. So I would imagine that most Ohioans will feel that when the orders are lifted and when we reach this 50 per 100,000, that the crisis will be over. Will it be over?
Well, I wish that I had the crystal ball to be able to predict this virus. So far, everyone that I have observed nationally who has attempted to make firm predictions about this virus has been wrong. So I'm going to avoid predictions, but what I can tell you is this. We're confident that when we reach that point, we're at a point where it is reasonable for us to lift those mandatory orders and requirements. However, and as I shared at the very beginning, I don't think that signals at all that we are done dealing with COVID. It simply means that we're at a phase where we can rely upon each other to make reasonable decisions in our personal lives about the safety measures that we undertake. And we at the Department of Health will still be providing guidance regarding safety measures that are recommended in various settings, although they may not be mandatory requirements. The people of Ohio have demonstrated a wonderful willingness to do the things that are necessary. And I'm hopeful and confident that they'll continue to do the things that are necessary even after we lift the mandatory requirements.
Thank you. Our next question is from Tom Jackson with the Sandusky Register.
Hi, Dr. Vanderhoff. I know you don't want to make predictions, but I'm still curious whether you think, whether you have an opinion on how soon we might be likely to reach this milestone to lift the health orders. Is it more likely to be weeks in your opinion, months? What is your feeling at this point?
Well, one of the variables that I can't predict very accurately right now is what impact the variants are going to have on the degree of infectiousness of this virus over the coming weeks. I would anticipate that they will have some impact, especially B117, the so-called UK variant, which, as I've shared before, we know is here in the state of Ohio and is in most states in the country at this time. So, assuming that there will be some impact from the B117 variant on the rate at which our cases decline, I would not expect that we will reach this threshold in just a few weeks. I think it will be longer than a few weeks. How much longer? I just don't know.
Thank you.
Our next question is from Jackie Borchert with the Inquirer.
Good afternoon. I've got a couple questions. I think my biggest one is what happens, I'm sorry, it's still not clear to me, are the health orders going away? Is that going to happen like when we hit 50? or do we have to be at 50 for a sustained period of time? And what happens if we are below 50 and then all of a sudden go back above 50?
Well, first, in terms of the first question, that is part of what I hope is the wisdom of using a measure that is a 2-week measure, a measure of cases distributed over the population, in this case, 100,000 cases per 100,000 over 2 weeks. So that when we hit that threshold of dropping below 50 cases over that 2-week interval per 100,000, it signals that we have had at least that 2-week period where that's where we've sat. So it already implies a more sustained level of performance. So that's the first piece. You know, the issue of, well, what will happen after this is again falling into the realm of, can I predict the course of this virus? I can't. I am optimistic that when we achieve this level, that it will be a signal to us that we are acquiring enough immunity as a result of vaccination, that it is that vaccination effort that is beginning to push this virus into the corner, that our vaccinations are getting this virus truly under control. But we can't let up when we get there. If we hit this number and we aren't continuing to go and get our vaccines when it's our turn, if we are not still being careful and using masks and distancing in appropriate settings, using our good judgment, then we could see this thing go the wrong direction. Obviously, if this went the wrong direction, we would have to return to the people of Ohio and say, this has gone the wrong direction. Here are the steps we need to take. I don't know what those steps would be. I can't make a prediction beyond saying we have to continue to monitor and do whatever is responsible.
Will Ohio be easing restrictions on our way to 50, or is 50 just the goal, and when we get there, they're all going to come off?
Well, I hope that you see that we already are in a process of easing many restrictions. And the governor in his speech last night painted some of that picture. We, of course, have looked at our gathering venues, whether they be indoor or outdoor gathering venues, and are working toward more generous limits on the percentage of occupancy in those venues. And I would expect that as we continue to move along, we'll continue to look at opportunities to responsibly open up our lives more and more.
Jackie's questions were the last ones that I had in the chat. I know, Jackie, you mentioned you have several. And is there anyone else who has a question? You would like to unmute yourselves or put it in the chat, please. I hear Sarah has a question. Sarah?
Thank you so much. Doctor, I know it's hard to be specific given how things go with the virus, but again, can you tell us when you expect us to meet that 50 cases threshold?
Well, as I shared before, I really don't know when we're going to hit that threshold. I can say that I am very confident that we will hit that threshold. We'll have to just watch, particularly what happens over the course of the next 2 to 3 weeks. That period of time is going to really give us an indication of what the B117 variant means to the state of Ohio, and what it means in the context of growing numbers of us who are getting vaccinated. We've never had the opportunity to see how vaccination and the virus work together. So far, what we've seen has been very encouraging in terms of the vaccine winning. I just want all of us to, though, continue our masking, distancing, and getting vaccine when it's our turn, because I really and truly believe that it's doing those things, masking, distancing, and getting our vaccine that gets us to 50.
Will it be by summer or fall?
I don't know. But I am really encouraged by the trajectory that I'm seeing right now. I mean, we have gone from numbers that were in the hundreds of cases per 100,000, and we are now below 200 and approaching 100 per 100,000 over a 2-week interval in the state. That's really encouraging. If the pace continues, obviously, we would arrive at that number in the very near future. But again, I'm expecting there will be some impact from the arrival of the B.1.1.7 variant. I just don't know how much of an impact, and no one does. There is no expert in the country, on the planet, who is able to provide us with that level of clarity.
Thank you.
We have a question in the chat that I will read, and then after that, our next question will be from Kevin Landers. The question in the chat is, will you provide the weekly numbers historically going back in time during the pandemic rather than the spot examples?
Yes, we are going to be putting that information together and making that available.
Thank you, Dr. Vanderhoff. And Kevin Landers, you are our next question.
Hi, Doctor. So when you look at the statistics, there are 11 states right now that have never had a mask order whose cases are higher. Most of them are higher than Ohio's. There are several states who are about to take their mask order off who have cases higher than Ohio. So why is there such a huge disconnect where you have states that are saying it's okay to take your mask off, yet still have higher cases than ours, but here in Ohio, we're saying still keep your mask on?
Well, every state takes a different approach. And Ohio, I think, from the beginning of this, has taken a very responsible and scientifically driven approach to trying to do the smartest thing we can. And Ohio is seeing a lot of success from the approach that we're taking. The key for Ohio and for the entire country to exit this pandemic is successful vaccination and safe practices until we achieve enough immunity from vaccination that this virus is no longer a threat. It's that simple. And what we have laid out, I think, is a very understandable, logical approach to responsibly reaching a threshold where we can say, you know what? It's clear that we are gaining enough immunity that we can begin to do what we all want to do, which is lift some of these mandatory restrictions.
Mark Ackerman has our next question.
This is a follow-up to Kevin's question. So how does other states' policies affect people here in Ohio? We know that like this corona spread so quickly from the East Coast to Ohio within days. Having a Texas or a Mississippi or all these other states who have weaker mask policies, how does that impact us here?
Well, obviously, we're impacted by the larger environment in which we live. But what we have an opportunity as Ohioans is to improve our lives here in Ohio. What we have the opportunity to do in terms of fighting COVID, in terms of winning against COVID, is working as Ohioans to safely and responsibly move towards our normal lives. We all want to get to a place where we're back to normal. Our focus has to be on what we do here in this state. And I'll tell you, the approach that we're taking and the approach that we've offered, I think holds up regardless of what is happening in states around us. Because what we're doing is we're looking for proof in the pudding. We're looking for evidence that we really are at a place where there's enough immunity that we have confidence in stepping away from some of these mandatory requirements. And I think that's the smart way to go.
Can we reach herd immunity without vaccinating children?
Well, that's a very good question. The challenge with answering any question about herd immunity is that really we'll know we've achieved herd immunity when we're there, which is, by the way, one of the other, I think, wise things about the approach that we're taking, looking at cases per 100,000. It's a fact-based indication of how the population is doing in the face of the virus. I am looking forward to the 12 to 18-year-old population being eligible for vaccines, particularly as we head into the next academic year. And I do think it will be important for us to include them in our vaccination program. But we're already showing that we're able to have a substantial impact on this virus. And yet we have only been able to vaccinate a subset of the population. So vaccinations are proving to be very, very powerful. We'll have to see when we achieve herd immunity, but regardless of the point at which we achieve herd immunity, think it will be a prudent and wise thing for us to include people younger than 18 in our vaccination program when that's proven to be safe and appropriate.
Rich Exner had a question that was answered in the chat related to finding the number of incarcerated individuals. There's a link the director put in there, and as well for that last 2-week period, that was approximately 100 cases. Does anyone else have any questions? Otherwise, we will let you go and thank you for your time. Jackie and Drew have questions. So Jackie, you're up next.
Sure. Dr. Vanderhoff, you mentioned at the beginning of the call probable cases. Can you go back to that and explain why probable cases are included? And why did you choose a case rate which is subject to fluctuations with holidays and increases in testing instead of something more stable like hospitalizations?
Okay, good question. So first, I'm sorry, the first question, I was thinking about the second one and I lost track of the first one. I'm so sorry.
Probable cases?
Yes, yes, probable cases. Yes. So those are just terms of art that have been part of the public health nomenclature. Essentially, early on, there wasn't the level of confidence in antigen testing that there is today in terms of true positives. We know now what we did not know when antigen tests first arrived on the scene. When they first arrived on the scene, we did not know that a positive antigen test was highly reliable, that you could take a positive antigen test essentially to the bank. We know that now. In our measure, therefore, we include not just PCR or so-called molecular tests, we also include antigen tests because both now are completely recognized as being legitimate positive tests. So that's the first question. And I should have kept your second one in my head and I didn't. I'm sorry.
That's okay. Why choose a case rate, something that's
yes.
more variable than like hospitalizations, which you guys have been using for other things?
Yes. So, no measure is perfect and every measure has its own shortcomings. And that's going to be true of anything that we look at. What we particularly like about the cases per 100,000 is that it is a real-time indicator. It gives you a really good indication over about that 2-week window of what's actually happening on the ground. People are not wanting to, and I understand this, wanting to wait for lagging indicators. The problem with very good indicators like our hospitalization rates, our mortality rates, is that they lag a good deal. We have consistently seen increases in percent of testing, in cases per 100,000 that have occurred well in advance of when we have then seen hospitalizations and mortality begin to rise. So as we were looking at thresholds where people could responsibly feel that they could start getting back to their everyday lives, we also thought it important to offer a benchmark that was a more real-time benchmark. Again, in terms of the concern about testing, it's a legitimate concern. What happens if testing goes down? Our recent experience has suggested that while testing will go down as there's less illness, and that makes some sense because you've got fewer people presenting to doctors' offices and other venues for testing. We have so much testing and such a robust testing program here in the state that I really don't anticipate that it will decline enough that it will invalidate this measure. As I said, even now, we're still testing in the neighborhood of 50,000 people. And that's despite the fact that our positivity rate on those tests is in the neighborhood of 3 to 4%. So our percent positives have dropped precipitously, and yet proportionately, we're still doing a lot of tests.
Thank you, Dr. Vanderhoff. And we have a question from Drew Simon with WHIO.
Hi, doctor. I had a question looking between, rural versus city impacts on these numbers. Just looking at yesterday's color map, it seems like the color map's going to be something that Ohioans are going to want to watch again. Just looking at Mercer County, for example, 70 cases per 100,000 people, Auglaize 87, Shelby 84. How should people be looking at the rural versus city impact on bringing this number down? Do city people need to be focusing in, honing in even more than, say, people in these rural communities? What impact will that have?
Well, it's a very, very good question. But what I would say that we learned as we went through our major surge in the late fall into the winter was that there's no part of Ohio that is truly isolated, that we're really in this together, and that the virus moves between urban and rural, and that the moment that we begin to think that one community is protected from all the other communities, the virus has proven us to be completely wrong. It is entirely predictable that there are communities that are going to be at the front of the line of getting down to this level, and communities that are going to be further back in terms of getting to that level of immunity. But the reason that we have set this target at a state level is because we know that it's going to be most reliable. We're going to have the greatest confidence when we see that collectively we're getting to this marker. But that does not mean there are not going to be communities that get to the marker sooner. They will, but nobody lives in a bubble. It is just not safe for one county to move away from our safety measures when other counties, perhaps right next door, are experiencing higher levels. Things are much more fluid than that in the state of Ohio, and our history has told us that.
Okay, those are our final questions. Director McLeod, Dr. Vanderhoff, if you would like to share any closing words, please feel free to do so.
Thank you so much for joining us today. Hopefully this has been helpful.
Thanks, everyone. Have a good day.